Rotation plasty. This is a reconstructive limb sparing surgical procedure for congenital and acquired lower extremity bone loss. In this procedure, the ankle joint becomes the knee joint and functions as one after the prosthesis is fitted. The limb is rotated 180 degrees in this case, as the ankle flexes in an opposite direction compared to the knee. Therefore, it is necessary that the limb be rotated 180 degrees, and therefore the name rotation plasty to the surgery. In this case, the plantar flexion action of the ankle is equivalent to the knee flexion. This surgery, rotation plasty, is commonly done in younger individuals and even younger children with bone cancer or osteosarcoma of the distal femur, proximal tibia, or even the proximal femur. In cases such as above, the tumor and the joint is removed and the ankle is reattached to the remaining part of the thigh. Van Ness was the surgeon who popularized this procedure for the management of proximal femoral focal deficiency, PFFD. As you can see in the figure, on the left is the view of what the leg looks like after rotation plasty. The ankle is reattached to the thigh, so you can see the ankle at the level of the other knee. So that's how it would look just after surgery. And on the right, the diagram shows you what part of the thigh and the leg is removed because there's a tumor in that part, either the distal femur or the proximal tibia. Could be either one, and then that part of the thigh is removed, and then the rest of the ankle, which is down there, you can see is reattached to the upper part of the thigh. Now there are several types of rotation plasty. Depending on where the tumor is, the rotation plasty procedure is done dependent on that, whether it's proximal tibia, whether it is distal femur, whether it is proximal femur. There are three types, mainly A1, which is distal femur, A2, which is proximal tibia, and B2, which is proximal femur. The type of rotation plasty helps determine the muscle action, whether it is going to be a gastrocnemius or a quadriceps dominant. Now, what are the benefits of rotation plasty? It allows for growth in a younger child, adolescent. The foot remains as the weight-bearing surface as before the surgery. It is a single surgical procedure, and since the ankle now acts as the knee joint, there is good control over the prosthesis, which eventually would be fitted to the individual. Preoperative physical therapy. It is very important that the individual undergoes some preoperative physical therapy before going into surgery. It consists of a thorough examination of the musculoskeletal and the cardiovascular status of the patient, the muscle strength of the muscles around the ankle and the hip are evaluated, and in case the strength is not adequate, then the strengthening of the respective muscles can be done. Stretching of the muscles can be done prior to surgery. Patient education must be given regarding the status of the muscles, and the brief preview of the extent of rehabilitation that will be needed after the surgery should be given to the individual, so that he or she has an idea that the level of rehabilitation after surgery would be quite intense, so that he or she could get back into the community and do all the activities that is needed. So therefore, it's better that you give this kind of an insight to the patient before surgery itself. Educating patient is a very important aspect of preoperative physical therapy. Now the post-operative care. The immediate post-operative care is the patient positioning, which is emphasized upon with the toes elevated off the bed. This are for several reasons: to prevent any kind of circulation complications, to prevent any kind of edema from forming. Patient is positioned in this manner. The first 24 hours, there is no movement given to the patient, whereas you start some amount of physical therapy on the second post-operative day, which is just active pumping of the foot, just dorsiflexion and plantar flexion of the ankle, and the active hip abduction and adduction movements, which can be started. Mobilization very gently can begin on this day too, with a few movement restrictions initially. Active range of motion exercises for the ankle can begin slowly in a few days, 4 to 5 days. Gluteal strengthening, now that is something to be emphasized upon, which can be done in prone lying at this stage. It is equally important to start the neuromuscular training, as there is presence of some amount of confusion due to the ankle now acting as the knee joint, because the ankle is reattached to the remaining part of the thigh, right? So for the individual, it's still like the knee is there, but it's the ankle that's been reattached. So there has to be some amount of training with respect to that has to be given to the patient. This training usually consists of just repetition of all active movements of the ankle. It provides good proprioceptive feedback as well. Activities of daily living, ADL, is also given to the patient. Transfer activities from the bed to the chair, the floor to standing is taught to the patient. Strengthening of the muscles around the hip and the ankle is enhanced. Now it's probably been like a week or more than a week. You can slowly begin with the strengthening, maybe just till grade 3, grade 4 for the individual, at least of the ankle muscles, and the hip too. Balance training is also emphasized upon because it's the ankle now which is attached and the prosthesis is not fitted yet. So balance training is essential now. Core strengthening exercises can be started. For instance, hip extension with abduction without any posterior pelvic tilt. So this just can be started even in the hospital. It's easy to start this. The position that can be acquired for this kind of exercise is also simple for the patient to perform. After this, we start with the prosthesis, the prosthetic fitting, which is a very important aspect after rotation plasty, because that is what is going to help the patient reintegrate himself in the community, do all the activities that he was able to do before. So this is a very important part of rotation plasty, and it is equally important for the therapist to be involved in this part in coordination with the prosthetist who has performed or who has crafted the prosthesis. It is usually fitted on the patient about 6 weeks post-op, and it is very important that the prosthetist be familiar with this procedure of rotation plasty, as the prosthesis must be crafted in a very specific manner. The socket type is dependent on the shape of the leg, the range of plantar flexion available, and the age of the child. So the prosthetist is going to perform a thorough examination before he or she makes the prosthesis, because depending on all these three things, the socket type will be prepared. Also depending on the type of surgery that is performed, whether it was for the distal femur, whether it was the proximal femur, accordingly the prosthesis will be fabricated. As you can see now in this diagram, prosthesis, the one on the left of the patient and the right of us, that is what the prosthesis would look like once fitted to the patient. The rehabilitation after the prosthetic fitting, as I said, must be very aggressive. The wear time of the prosthesis should gradually increase. Gait training with the prosthesis begins. Initially, step standing, which usually you can do with a visual feedback such as a mirror in the front, can be given. Parallel bar gait training can be given within the prosthesis. Progression to walking with support, either crutches or walker, then eventually off the walking aid within a few days or even could take a few weeks. And while all this rehabilitation is taking place, intermittently the skin should be checked for any kind of blood clot or any complication due to any tight prosthesis. And if there is any problem, it must be rectified immediately. The The patient here might prefer to use circumduction, which is commonly seen as a pattern of gait, which must be discouraged. Instead, hip hiking can be encouraged. It is better than circumduction. Eventually, even weight bearing in stance is encouraged in order to prevent hip hiking. Now you can start the gradual progression of stair climbing. Upstairs and downstairs both can be trained in the patient. Patient can be seen every 1 to 2 weeks initially. Basically, strengthening of the gluteals, the ankle musculature, gait, balance training, cardiovascular reconditioning is what is emphasized upon for these 1 to 2 weeks that the patient is seen initially. It usually takes about 2 years for these individuals to have a normal gait. It is also important that we offer support to the individual with rotation plasty and help him or her build a social image so that he or she can have a life outside. Reintegration into the community is an important step. So the recognition and improvisation of personal image also must be built upon with help from the therapist. During daily rehabilitation sessions, it's very important that we talk to the patient and tell him or her that it's all back to normal now and he or she can do all the activities that they wanted to perform. And that will help motivate the patient and reintegrate him into the community so that he has a social life. Accommodations at school also must be encouraged, keeping in mind the fatigue that can be faced by the child because prosthesis involves increased energy expenditure. So we must, as therapists, also be involved in that. We must talk to the school authorities and tell them that this child might be facing certain fatigue issues, eventually which could disappear due to cardiovascular conditioning that we could encourage the child to do if possible. So therefore accommodations at school must be made accordingly. Finally, when the bony union is achieved, the activity level of the patient can be increased so as that it matches the patient's desire. Activities that improve fitness, strengthening if required, as the patient may have some demanding daily activity needs that should be met. The person might be very outdoorsy, the person might want to do a lot of activities outside, which might take a toll on the fitness level present in the individual at that point of time. So it is very important that we improve fitness. Also, the wear and tear of the prosthesis should be looked for intermittently, and studies say that a reassessment should be done at least every 3 to 4 months, which includes the assessment of the muscle strength, the range of motion, the gait analysis, what kind of a gait pattern the child or the individual has finally taken up, and whether we have to make any modifications for that. Therefore, reassessment is a must in patients who have had rotation plasty. Thank you.